antiphospholipid, everything's good. Thank you. Amerantic endocarditis or LV thrombus. And then there are those case-based scenarios that not everyone will be a candidate for anticoagulation. It will just depend on the expert opinion and what you usually would do in those matters. Something like unstable plaque, or if there's a free-floating thrombus, personally, I would anticoagulate those for short-term period. If we think this stroke is related to hypercoagulable state, like an active cancer with high D-dimer, and even now in patients with COVID who have had COVID-related stroke. And those patients who will need anticoagulation for other reasons than their strokes, but we cannot continue their anticoagulation due to their stroke in the acute phase period. Just remember, majority of the evidence that we'll be talking about has been driven from AF-related strokes. So overall, balancing risk and benefits for oral anticoagulant has been for the long term rather than for the acute term of or short term of when we start those anticoagulation immediately after a stroke. So the risk of embolization have been overall balanced between clinical features like previous history of stroke, TIA, diabetes, old age, hypertension, and there has been some evidence that even the longer you are in atrial fibrillation, that will predispose you more to having a stroke related, and some echocardiogram features that will just make them more prothrombotic overall from atrial fibrillation. And this has been transferred into CHADS-VASc risk criteria or CHADS-2 or even CHADS-65, depending which region you're going to talk about. And accordingly, there has been a calculation, but again, remember, this calculation is annual, it's a year-based and not necessarily for the acute phase after. Bleeding risk, again, it depends on the choice of anticoagulant that we choose to start them on, whether it's going to be a DOAC or vitamin K antagonist, how we started, the role of bridging beforehand, the dose is appropriate or there's supratherapeutic on it, and some patient-related, like we know elderly, Asian, those with prior bleeds and certain bleeds and certain comorbids like liver disease, kidney, concomitant antiplatelet medications with anticoagulation, thrombocytopenia, all of those will predispose them to having a bleed. This again has been translated into a different scoring system, but just remember those scoring system, none of them should overrule your clinical judgment as a physician on how much the patient needs anticoagulation versus the risk of having a bleed related to those anticoagulation. Then again, those criteria, has blood and atria and all of those scores doesn't really necessarily focus on intracranial bleeds, which is what we care about as a neurologist overall, because that seems to be associated with the highest morbidity and mortality when we talk about anticoagulation related to bleeds. So factors like history of prior stroke, uncontrolled hypertension, CAA, having cerebral microbleeds, intracranial vascular malformation, brain tumor, history of drug abuse or falls, endocarditis, all of those will predispose them to having more bleeds. This is an interesting case control study that was published this year, actually. They tried to look into DOAC and the risk of intracranial hemorrhages. So they took those AF patients on DOAC who have had bleeds, intracranial specifically, and compared them with those AF patients on DOAC for more than a month without a bleed. And they found that the older they are, hyperlipidemia, creatinine clearance, concomitant use of antiplatelet therapy, and white matter changes have been significantly associated with increased risk of intracranial hemorrhage. Interestingly, neither CHADS-VASc nor has blood scores actually worked on those NOAC patients in predicting their risk of having future bleeds. Now, going back to atrial fibrillation and stroke, so we know anticoagulation will reduce lifetime risk of recurrent stroke in those patients from 12 to 4%. In the acute phase, we always need to balance between the risk of having hemorrhagic transformation and having recurrent stroke. This is the highest for both in the first 2 weeks. It's thought to be 1.3% per day for the hemorrhagic transformation and 0.5% per day for the recurrent ischemic strokes. Just a reminder that not all strokes are the same. So we have those perforator strokes that can be small and they don't necessarily have a higher risk of hemorrhagic transformation compared to embolic. MCA strokes also could happen in different sizes. So not just when you say MCA stroke, that means you have to delay anticoagulation. Sometimes a stroke is so small and will qualify for an early anticoagulation. And a quick reminder of hemorrhagic transformation classification based on ECAS-2. So we have those A and B, which are hemorrhagic infarction 1 and 2, and we have C and D, which are parenchymal hematomas. And those usually the ones that tend to be symptomatic. And again, when we say symptomatic, we usually mean increase in NIHSS score of more than 4. The overall incidence of spontaneous hemorrhagic transformation on autopsies had been up to 70%, whereas on CT alone up to 43%. But remember, again, the symptomatic ones up to 20% only. And we know there are certain risk factors that will predispose those patients more so to have hemorrhagic transformation. Again, sometimes as an evolution course of the stroke itself, that they would have hemorrhagic transformation. So it's not necessarily a mistake or something went wrong through the management of patients, but factors that we can help out in reducing this risk is predominantly controlling the blood pressure. I don't want my patient to have very, very high blood pressure throughout his course in hospital. We usually just keep that blood pressure labile for the first 2 days if they did not take any acute reperfusion like IV TPA or thrombectomy, and afterward, we lower it gradually. For those who have had acute reperfusion management, usually we target less than 180, but the same thing, we also lower it gradually. And this will specifically matter after we start the anticoagulation, how strong we need to control blood pressure. Quick reminder that all the large DOAC trials, RELY, ROCKET, ARSTOL, ENGAGE, none of them actually have included patients with acute stroke. They all excluded patients with recent stroke from 1 week after the stroke to 6 months after their stroke. So those patients were not really part of those studies. And unfortunately, when we try to look into our evidence as anticoagulation after ischemic stroke, you'll notice that most of our evidence have been observational and retrospective. The two large ones that I will focus about by Dr. Baccheroni and his colleagues, BRAV and BRAV-NOAC. So regarding RAF, this is a prospective observational study in Europe and Asia that looked into patients with acute ischemic stroke and atrial fibrillation who will need anticoagulation and they don't have any contraindication for it. The study outcome predominantly has been for looking into ischemic events, so that's recurrent ischemic stroke, TIA, or symptomatic systemic ones, and looking into also symptomatic cerebral bleeding or major extracerebral bleeding. This study included approximately 1,029 patients. Of those patients, 74.4% treated with anticoagulation and the rest did not receive anticoagulation. Looking into how they divided those anticoagulation among those patients, you find that approximately 37% received warfarin from those patients, and interestingly, 36% received low molecular weight followed by vitamin K. So there was some bridging going on in this one. The overall hemorrhagic transformation in those patients in this study has been approximately 13%. Patients who have received reperfusion therapies, 22.4%, and only 16.1% of those have had hemorrhagic transformation, of which 6.1% was parenchymal hematoma. And again, those patients who have had an outcome, whether that was a bleed or ischemic, compared to what I just said, has been 11.7 in those who received anticoagulants and 14.4 in those who did not receive it. And if you look into the ischemic specifically, you find that they actually do better if you do start them on anticoagulation with a p-value of 0.023. Now, the mean time of when they were starting the anticoagulation after the stroke has been different depending on the agent that was used. You'll notice it was the shortest for those with low molecular weight heparin, and for vitamin K antagonist seems to be the longest. Now, for predictive factors that will predispose to any outcome, so the severity of the stroke, NIHSS, has been associated. The size of the stroke, the larger the stroke, the more likely they will have an outcome associated. Similarly with the Chad-Vasquez stroke as well, Chad-Vasquez score, and if they have had any bridging going on. Now, specifically for the ischemic outcome, they noted that the age and the large stroke has been associated. And regarding the hemorrhagic outcome, again, they noted that bridging has been associated and the size of the stroke also has been associated. Then they tried to look into the timeline of when those anticoagulation have been started after the acute stroke. So during that time period, they noted that the outcome have been reduced for those who were started between 4 and 14 days. Specifically, the ischemic outcome has been less for those patients. Then RAF-NOACs, again, by similar to group, also including Europe, United States, and Asia, another prospective observational that looked specifically for AF and acute stroke who were started on DOAC. So this one had included approximately 1,127 patients. The distribution between dabigatran, rivaroxaban, and apixaban has been the same. At the time of this one, edoxaban has not been out yet and commonly used, so it was not really quite included. 62.7% did receive antiplatelet until it was thought to be okay to be started on anticoagulation, and 9.6% still received low molecular weight bridging for those patients. Only 2.2% were treated concurrently with NOAC and antiplatelets. And again, hemorrhagic transformation on imaging seen in 9%. So overall, 5.2% have had an outcome, of which 2.8 were ischemic and 2.4 were bleeds. But you notice that the overall outcome for ischemic and hemorrhagic for those like NOAC had been 60% lower than the rat population that has included vitamin K antagonist. Again, when they try to distribute it by time, whether we started within 2 days, within 3 to 4 days, or after 14 days, the best benefit for reducing risk of outcome had been for those who were started between 3 and 14 days with 2.1%, whereas if you started earlier, it will be 12.4%, and if you started later, it will be 9.1%. When they tried to look specifically into each factor, they couldn't really build any unbiased opinion over which one will be better and which one will reduce the outcome better. The percentages overall seems to be variable, but there has been nothing significant in those numbers. IAC is a more recent, was published last year, another multi-center retrospective collaboration for anticoagulation after stroke. They had two main targets. They wanted to look into the role of bridging and trying to compare between DOAC and warfarin. And the outcome, again, similar had been for a recurrent ischemic event and delayed symptomatic ICH. So for those, when we tried to compare DOAC with warfarin, they had approximately 1,251 patients. Of those, 69% were on DOAC, and majority of those have been on factor 10 inhibitors. And what they found was that the recurrent ischemic events have been less in those on DOAC compared with warfarin. And the delayed symptomatic ICH, there was a trend for less with DOAC, but it was not clinically significant. This is again the similar group IAC as well. They tried to do it by based on timeline differentiation. So they did 0 to 3, 4 to 14, and more than 14. And predominantly of those have been therapeutic anticoagulation as 0 to 3. But again, similar thing, they did not find significant difference in composite endpoint between the three groups. So it didn't really have any significant results on when those were started. What they noted, however, it was like the timeline after, the timeline was kind of still going in between those 4 to 14 that seems to be doing better. This is just a quick reminder of this new publication, REST study. That was the first RCT that looked into apixaban versus warfarin for acute stroke and indication for anticoagulation with AFib afterward. Unfortunately, none of those have been positive for numbers. Again, there was a problem with the warfarin dropouts from that group. So further problems when the guidelines in 2019 came that have recommended starting with DOAC over warfarin. So it was not appropriate at that point to enroll more patients into the warfarin group. Now, this is another prospective multi-center, but it was interesting because they tried to compare the timing of starting anticoagulation for anterior circulation stroke versus posterior circulation stroke. So they had about 473 patients with posterior circulation stroke, and they compared it with RAF and RAF NOAC population of anterior circulation stroke that has been about 1997 patients included. And in this one, again, they did not find a significant difference between the two groups regarding all types of outcome. So ischemic or bleed whatsoever between the two. What they did find, however, is that the most benefit would happen within the, like after 10 days if you started. Now, if you try to compare, I think if I use the mouse, something will pop. Let's just, okay, pop good. So if you try to compare here between like the 8 and 14, for the combined outcome, it was 8% in the anterior circulation, and the 8 to 14 was 6.8% for the posterior circulation. If you look for the ischemic, it was 3.4% for the posterior circulation, and it was 3.8% in the anterior circulation. Again, looking into the 8 to 14, 3.7 for hemorrhagic, and it was somewhat higher for those with posterior circulation. Then they tried to look into the size of the stroke. So those more than 1.5 centimeter considered as a large stroke, and small stroke less than 1.5 centimeter. And they found that the larger the stroke, the higher the chance of having hemorrhagic endpoint. This is just a quick reminder that they also tried to look into starting anticoagulation for patients who have received acute reperfusion, and they did not find that it would increase the risk of having a bleeds or a change in their outcome afterward. So we can still keep in mind the same time window we have if this patient had received IV thrombolysis. Now, the question of bridging, this is a combined paper between both RAF and RAF NOAC population, and they tried to look overall the benefit of bridging. So they took those from each group and put them together, and they did not, the result was significant where the outcome overall combined had been increased. So there was really no benefit of bridging. Both ischemic outcome and hemorrhagic outcome had been increased for those who had received the bridging prior to anticoagulation with oral agents. Now, IAC, as I mentioned earlier, also looked into it. So approximately 203 patients were started on bridging in this population. And the median time from starting the bridging therapy to initial oral anticoagulation was shorter in those with warfarin. But similarly, you notice that the delay in the time to delayed symptomatic ICH was actually higher in those who have been started on bridging without difference in lowering the ischemic outcome. So it just added more bleeds without any benefit. Now, guideline-wise, talking about what we have so far as a recommendation, AHA publication had been in 2019 again, and they just recommended between 4 and 14 days. In the Canadian Stroke List Guidelines, which is unfortunately the oldest of all the guidelines, is stuck with the 1, 3, 6, and 12 rule of 1 for TIA, 3 for mild stroke, and 6 for moderate stroke, 12 for severe stroke, emphasizing that we don't really know. EHRA guidelines, so initially they just went with 1, 3, 6, and 12, but interestingly, more recently, they made it more practical. So now they focus on the importance of the brain imaging, the importance of having hemorrhagic transformation already, if there has been any change in the clinical presentation of the patient, if they have had any clinical worsening throughout, and accordingly, they just mentioned like a graph on how we can go ahead. And this is all like just something based on expert opinion. ISO recommendation used to be 4 to 14 in 2016, but more recently, they just acknowledged that in reality, we don't really know, and they emphasize the importance of enrolling those patients in RCTs. This is the best for non-neurologists, I think, because again, it gives an idea about the NIHSS and how we can calculate the severity according to, and some factors that will prompt us to starting anticoagulation early versus some factors that will prompt us to delay starting anticoagulation for those with stroke. This is a Korean retrospective that tried to see if there's any change in outcome if we do follow European guidelines of 2016 that I just mentioned. And interestingly, in this one, they did find that actually ischemic stroke better. So even though our recommendation had been expert opinion, they do work. Now, having a stroke in spite of oral anticoagulation in this 7 prospective cohort studies put together, they found approximately 1,195 patients were on anticoagulation and have had acute stroke or TIA. And those patients who have had a stroke on prior anticoagulation, they usually have had higher cardiovascular risk factors, even though their CHA2DS2-VASc score and HAS-BLED score have been the same. And changing that anticoagulant agent after the index event was not really associated with decreased risk of further ischemic stroke. So overall, those patients tend to stroke because number one, for me is those oral anticoagulant agents, they don't prevent a stroke 100%. Just remember that strokes happen overall. One cause is atrial fibrillation, but it's not the only cause. And even for those atrial fibrillation related strokes specifically, it's not a 100% prevention for those. And sometimes there will be a non-compliance issue, there will be a drug interaction issue. And if the dose was not appropriate, which seems to be one of the biggest issues that I've seen so far, unfortunately, especially with NOAC. Remember, just because your patient looks frail does not mean he will qualify for apixaban 2.5. You actually care about the age, creatinine clearance, and the weight of the patient before we say this patient will benefit. Think about it on the long term. If you get this patient back in the future with a stroke because the 2.5 was not sufficient, you cannot give them TPA because they already have some anticoagulation in their system that's not sufficient. You gave them this because you thought this patient was frail, and then you're limiting yourself with the option of thrombectomy because not all interventionists will be welcoming taking in a patient with MRS of 3 or 4 for thrombectomy stroke. And technically that stroke could have been prevented had the patient had a full proper dose of anticoagulation. Now, those two just information here mentioned that, again, it's a 1% year risk of having embolic stroke on warfarin, 1.4 for NOAC. And lipid out paper actually identified coronary artery disease and smoking as additional risk factors for thromboembolic in those patients anticoagulated on for atrial fibrillation. And this is just a quick reminder, again, that there is no evidence that we need to add aspirin for those patients if they stroked on anticoagulation or whatsoever reason from stroke perspective. The only exception I would say is if the patient have a stroke with symptomatic severe carotid stenosis, that they will go for carotid intervention. I would probably keep them on aspirin and anticoagulation prior to their intervention. So now for aspirin, until it is safe to start them on anticoagulation, we don't really have a big data to tell us what we're supposed to do. IST and CAS trials have been like an old one that showed that aspirin will reduce the risk of future stroke overall, regardless of the cause. We know that aspirin does not prevent a stroke for atrial fibrillation, like it's not an option for atrial fibrillation specifically. However, because as we said earlier, those patients also have other risk factors, and stroke does not necessarily happen only due to atrial fibrillation. I do think it's reasonable, and even with the ESO expert opinion, that it is good to keep them on antiplatelet until it is safe to start them on anticoagulation. And with AIR as well, they emphasize that if you think the stroke happened on anticoagulation, you remove the anticoagulation, you start the aspirin, and you start it once you think this anticoagulation is out of their system so that they don't get any sort of dual antithrombotic until then. Again, just a reminder, we don't recommend aspirin or combination for stroke prevention atrial fibrillation, especially after DOAC and after apixaban with almost similar risk of a bleed. So it just doesn't make sense at that time to start them on aspirin. We do have some ongoing trials that's looking for starting anticoagulation after stroke, specifically looking for those with DOAC with different time window to try to help us when is the best time to actually start them. In conclusion, we know that anticoagulation will benefit those patients with a stroke and atrial fibrillation in order to prevent more strokes. We just don't know yet when is the best time. We definitely don't want to do any bridging before we start them on their oral anticoagulant agents. And while stroke on anticoagulation tend to be milder and tend to happen, there is no absolute indication to change it to a different agent. Not necessarily right, not necessarily wrong. We just don't have an evidence on what we're supposed to do for those right now. So it is okay if we just want to continue the same DOAC, assumingly that they are at the appropriate dose and the appropriate choice of anticoagulation. Thank you very much.